This is the second webinar in the Engaging Subpopulations of Clients Experiencing Homelessness with SMI or CODs series. My name is Zach Stewart. I'm going to be your producer for today's event, and before we get started here, I am just going to do a couple quick housekeeping slides for us. I want to let you know this event is being recorded today, and audio is now broadcasting, so you should be hearing my voice. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or the policies of the Center for Mental Health Services or the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. We are providing live captioning for today's event. You can access those captions by clicking this link on the screen right here, and I've also pinned that to the top of the All Questions box, which is located right underneath the slides. You just click that link and a new tab or window is going to open on your screen, and you can adjust that and move that anywhere you like. And you can adjust the size, color, and speed of the captions. Your line is going to be muted for today's event, but we do have some ways for you to communicate with us. First is that public chat box, which is located right under my picture there to the right of the slides. You're going to be able to find that throughout the event in that location today. I see many of you have already started typing in there. Just be aware that anything you type in that box is visible to everybody in the room. So while we get started, just as a quick practice for typing in that box, just say a quick hello and let us know where you're calling in from today. As I mentioned, we do have that All Questions box, which is going to be located right underneath the slides. Please do use that for all of your questions today, tech and content. We will save your content questions for the Q&A session at the end of today's event, and then we will be able to answer your tech questions right in that box. And with that, I'm going to pass things over to our moderator today to get us started. Sherry, are you with us?
I am. Thank you, Zach. Welcome, everyone. We are so delighted that you're here. I am going to introduce Doreen Gross to begin with. We are delighted to have Doreen with us. She's the PATH Program Coordinator in SAMHSA's Division of State and Community Systems Development. Ms. Gross has more than 20 years experience working with grants and contracts portfolios associated with individuals who are at risk of or experiencing homelessness. She has worked with many federal partners, including United States Interagency Council on Homelessness, Department of Housing and Urban Development, Administration for Children, Youth, and Families, and many others to coordinate services, policies, and housing and homelessness-related activities. She also served as the Contracting Officer Representative, or CORE, on the Homeless and Housing Resource Network Technical Assistance Contract, which is bringing you this webinar today. She holds a master's degree in social work from the University of Maryland. Doreen, over to you and welcome.
Okay. As we know that the pandemic has changed all of our lives, but it is especially difficult for people experiencing homelessness who have a serious mental illness or co-occurring disorders. For those of you who work in the field, you have had to adjust how you do your jobs, and SAMHSA is here to help. I encourage you all to visit the website that SAMHSA has set up for helping individuals, providers, communities, and states respond to the pandemic. The page is, that page is samhsa.gov/coronavirus, all one word. Today we are focusing on a particular vulnerable subpopulation that continues to grow. In 2007, only about 23% of sheltered adults were over the age of 50. In 2017, that figure had increased to 33%. During the same time, the percentage who were 62 and older doubled from 4% to 8%. In past programs, the percentages are similar, with 33% over the age of 50, including 7% who were 62 and older. Today's presentation presenters will teach us more about the needs of those older adults, as well as some of the resources available to them. On behalf of all of SAMHSA, Thank you for the work you do, and we hope you find today's presentation helpful. I'll turn it back over to Sherry, our moderator. Sherry?
Thank you, Doreen. I appreciate it very much. All right, so today we are very excited to bring you three very knowledgeable presenters. Dr. Margot Cashel is a professor of medicine in the Division of General Internal Medicine at Zuckerberg San Francisco General Hospital and Trauma Center. She is also the director of the UCSF Center for Vulnerable Populations. Her research focuses on reducing the burden of homelessness on health by examining efforts to prevent and end homelessness and mitigating the effects of housing instability on healthcare. She uses her research to inform the development of programs and policies to end homelessness and understand the complex interactions between health and housing. She has a particular interest in homelessness among older adults and medically complicated people. She has served or is serving as the principal investigator of numerous federally funded projects. Dr. Cashel works with diverse stakeholders to implement programmatic and policy changes based on her research. She maintains an active clinical practice in primary care and inpatient medicine as well. An aside, that is a lot, and I know Dr. Cashel has been extremely busy given the COVID crisis, so we're grateful that she's here today. So welcome, Dr. Cashel. Sherry Clark also joins us. She is a Senior Aging Services Program Specialist within the Office of Supportive and Caregiver Services of the Administration on Aging. That's an agency of the U.S. Administration for Community Living, or ACL, under Department of Health and Human Services. The ACL provides national leadership and direction to plan, manage, develop, and raise awareness of long-term services and supports that enable older Americans and individuals with disabilities to maintain their health and independence in their homes and communities. Ms. Clark also manages several consumer information projects, including the Elder Care Locator, a toll-free telephone line and website that connects older persons and their caregivers with community services and opportunities at state and local levels. In addition, Ms. Clark also manages a diverse portfolio of grants focused on home modifications, engaging older adults, and volunteerism. She has held several positions within AOA/ACL in the past 20 years, and prior to that, she worked for 10 years with the Social Security Administration. She's a native of Washington, D.C., and holds a Master's of Social Work degree from Howard University. Finally, we have with us Brett Esters, a Senior Program Specialist in the Office of Special Needs Assistance Programs at the U.S. Department of Housing and Urban Development. And that's the office within HUD that oversees programs dedicated to housing people, individuals, and families experiencing homelessness. She serves as the lead for regulation and policy development and works to ensure HUD requirements and policies promote the goal of ending homelessness, support the effective use of continuums of care and emergency solutions grants funding. Brett holds a Master's in Social Work from Columbia University. So with that, we have three wonderful presentations for you. And without further ado, I will hand it over to Dr. Cashel. Doctor?
Thank you so much for having me and for everyone for joining. I'm going to talk about homelessness in older adults with a focus on the causes, consequences, and solutions. First, I want to talk about why we think the homeless population is aging and just the fact that it is aging. Very briefly introduce you to the study where we get this data from, talk about the demographics of older homeless adults in Oakland where we did this study, describe the pathways into homelessness or how people became homeless, their health status, health service utilization, institutional care mortality, and then housing outcomes. And finally, because this talk can be endlessly depressing, I'm going to end with talking about some interventions and solutions. Where do we go from here? So first of all, the homeless population is aging. The proportion of single adults who were over 50 in San Francisco in 1990 was about 11%. When we ended this study in 2003, it was 37%. Now it's about 50%. This turns out to be a generational issue. My colleague at the University of Pennsylvania, Dennis Culhane, and colleagues showed that Americans born in the second half of the baby boom, approximately 1955 to 1965, had an elevated risk of homelessness throughout their lifetime. So when they were in their early 30s, the big population bubble of people experiencing homelessness were in their early 30s, and likewise, now that they're in their 50s and 60s, that's where there is a big population boom. This aging is expected to continue until about 2030. In fact, the population of people 65 and older experiencing homelessness are anticipated to triple between now and 2030. The real reason that we have a homelessness crisis is because of our shortage of what we call extremely low-income housing. That is housing that is both affordable and available for low-income households. And extremely low-income households are households who make 30% or less of the area median income. That is a different amount of money, obviously, in, for instance, rural Georgia than it is in the San Francisco Bay Area, but every region has their own median income. What we know nationally is that there are 35 units of housing that are both affordable and available for every 100 extremely low-income households. Those are the households that make less than 30% of the area median income. By affordable and available, we mean that the house is habitable, isn't occupied by someone who makes more money and could actually afford a higher rent household, and that is affordable with that household spending 30% or less on their rent. Until we close this gap in extremely low-income housing, we are not going to make a lot of progress in solving this crisis. I want to remind everyone that homelessness is a racial justice issue. In this country, housing has been the primary means of wealth building. And I want to remind everyone that there has been ongoing discrimination in home ownership that for many, many years was written into our laws and systems, where they were neighborhoods that were segregated using racial covenants. This was perfectly legal to do at the time. And then the banks, again, perfectly legally, were allowed to restrict access to mortgages in those segregated neighborhoods, effectively leaving communities of color, particularly Black Americans, out of the housing market. We know that this community, that Black and brown communities, were disproportionately impacted by the predatory lending crisis leading to the recession in 2008. And we know that even though now it is illegal, there is ongoing discrimination in the rental housing market such that Black families wind up paying more for the same housing as white families do. You add to that the well-documented and ongoing discrimination in the criminal justice and employment systems, as well as educational discrimination, which is of course linked to where it is that people live. It is perhaps not a surprise, but a truth and a tragedy that Black Americans are at 3 to 4-fold increased risk of homelessness. Indigenous Americans or Native Americans are at an approximately 8-fold increased risk. I want to very briefly introduce you to our study. This is the health outcomes of people experiencing homelessness in older middle-age study. It's funded by the National Institute of Aging. It's a longitudinal cohort study in Oakland, California. We enrolled 350 participants who we enrolled between July 2013 to June 2014 and followed them every 6 months. We enrolled an additional 100 participants in 2017 or 2018. To be enrolled, you had to be 50 and older. You had to meet the federal definition of homelessness when you were enrolled, but we follow you whether you remained homeless or become housed. And you had to be English speaking because our community advisory board told us at the time we started the study in this age group, the vast, vast majority, over 98%, were English speaking. So what did we learn? We learned that among a population of homeless individuals where everyone had to be over 50, 2/3 were between 50 and 60 when we enrolled them in the study, but 12% were 65 and older. That said, as the population has aged, we've seen the age distribution change. We found, like many studies of homelessness, that 3/4 of the participants, or 77%, were men. 80% were African American in a city that at the time we did the study that was 26% African American. While homeless and everyone was older, 13% were working at the time we enrolled them more than 20 hours a week in the formal economy, and almost an additional third, or 28%, were actively looking for work. Despite this, 90% had a household income of less than $1,150 a month in a very high-cost region, reminding everyone that homelessness is really an after effect of severe poverty. Almost a third of the people in our sample had lost their stable housing in the past year. And stable housing has a very strict definition. This was a non-institutional place that people had lived in the same house for the past year. When we looked at it a different way, which was how long has this episode of homelessness been, a third of people's episode of homelessness was for less than 6 months. That said, for 15% of our sample, they had not been stably housed for over 10 years. So how did people wind up living on streets and in homeless shelters after the age of 50? The first and perhaps the most important thing I'm going to say, perhaps the most important slide in the talk, that of everyone in the study, and remember, to be in the study you had to be homeless and you had to be 50 and older, 44% had never had an episode of homelessness before the age of 50, meaning almost half of the individuals had never once been homeless before they were 50. We found that those with early homelessness, those whose first homelessness happened at any point, even for a day before the age of 50, compared to those who were first homeless after the age of 50, those who were first homeless before the 50 had many more what we would call adverse life experiences beginning in childhood with deeply traumatic childhood. They had low income attainment in early adulthood resulting from these traumatic childhoods. They were much more likely to have no spouse or partner, to experience mental health problems, traumatic brain injury, have a history of imprisonment in the state or federal prison system, and to have a significant alcohol use disorder. One of our participants who had been homeless on and off, but mostly throughout his life since his mid-teens, described to us the moment he became homeless when he was a teenager. My father said, next time, if you run away, I'll beat you with a car chain or I'm going to throw you out the window. Okay, so I wouldn't use the word reasonable, but I put things in perspective real quick. And I would say, could I survive his car chain? Probably not. Then I looked out the window and said, and we lived on the 13th floor, I said, I ain't playing with this man. He went to work, I had whatever I had on me, and I was out the door. This young man left his home facing significant violence, went to the streets where he has mostly been living ever since then, up until the time we met him in his late 50s. Those, however, who had their first homelessness after the age of 50, the 44%, had very different stories. These individuals had worked throughout their lives, although they had worked in low-wage, physically demanding jobs. They did so until some crisis hit, and that crisis was one of a few things. It was either they lost their job or their spouse or partner lost their job, marriage broke up, they became ill and could no longer work, their spouse or partner became ill, or their spouse or partner died, or their parent died. We had many people who were working low-wage jobs, living with mom. Mom died in her late 70s or early 80s, and usually it was a son who had been living with her, then lost the ability to stay in that housing and went into homelessness. We found a profound lack of advocacy, people being evicted for reasons other than non-payment of rent, people not getting benefits to which they were qualify, and people facing multiple bureaucratic hurdles. Everywhere they turned for help, they found a shut door. We saw low social support, and it wasn't so much that people didn't have friends or family, it was that they had such deep shame about becoming homeless that they didn't access the support and they didn't tell anyone. They were much less likely to have imprisonment or long incarceration, but their housing had been hampered by one-time charges, usually a drug charge or an unexplained arrest earlier in their lives, which hampered them throughout their lives in both the employment and housing market. This is one of our participants talking. When they bought the company out, they cut our hours back, and they would bring in temp workers, and they would give them all the hours, and they weren't giving us our hours, which caused me to lose my place I was staying in because I couldn't afford to pay the rent. Because, you know, when you're going from 80 to 100 hours a week, which is what he had been working, down to 20 hours a week, it's kind of hard to pay the bill. Well, those with late onset homelessness tended to have fewer vulnerabilities. Many had significant health challenges related to their homelessness. So let's talk about their health status. 56% of all of our participants reported their health as fair or poor. Fair or poor health is a strong indication that you're going to wind up in the hospital or wind up dying in the next year or so. In the general population, about 11% report their health as fair or poor. The only population where 56% report their health as fair or poor are those frail elders in their 80s and above, but the median age of our population was 57. We found a very high proportion with functional impairments. You can see that almost 40% had a limitation in activity of daily living, dressing, bathing, toileting, transferring, and the like. And most of those actually had 2 or more. If you have 2 or more impairments, you're at high risk of requiring a nursing home. Almost half had an impairment in instrumental activity of daily living, things like being able to take public transportation or call and make a doctor's appointment. We found a very high prevalence of cognitive impairment as done through the 3MS test, which shows global cognitive impairment or impairments in memory, impairments in judgment, and other things, with almost a quarter showing impairment in the 3MS or global cognitive impairment. When you looked at the 12B test, which measures executive function, and executive function is the ability to follow a sequence of commands. Things like, oh, if you want to get housing, you need to go to this office on a Monday, Wednesday, or Friday before noon, fill out the form, and then bring it to that office. That is exactly what people with executive function can't do, and yet 35% of our participants had executive function impairment. We found a very high prevalence of all geriatric conditions. You can see that over a quarter had mobility impairment. 34% had fallen once or more in the prior 6 months. 45% had visual impairment, 36% hearing impairment, and almost half had urinary incontinence. You can imagine trying to apply for a job or housing when you have no place to change your clothes and you suffer from urinary incontinence. All of this leads me to say that when you talk about homeless adults, 50 is the new 75. The median age of our sample was 57, but the prevalence of geriatric conditions was worse than that we see in the general population samples in their 70s and 80s. Alcohol and drug use problems were common. 2/3 of our participants had moderate or greater severity of drug use symptoms, with cocaine and cannabis being the most common drugs, and 1/4 had moderate or greater severity of alcohol use symptoms. 15% had severe alcohol problems. That said, I will go back to the slide a bit, that said, one thing I should note is while these problems were common, they were less common than we see in younger homeless adults, but much more common than we see in adults with a median age of 57, and hugely more common than we see in adults in their 70s and 80s who might be the more appropriate group. And you can imagine the problem of doing drug or alcohol counseling and work in a population with all of these other age-related impairments. Mental health problems were common, with depression affecting more than 1/3, post-traumatic stress disorder about 1/3, and about 20% had ever been in a psychiatric hospital, and about 5% had been in a psychiatric hospital in the prior 6 months. So about health service utilization, institutional care, and mortality. About 3/4 of our participants had a source of care, like a health clinic that wasn't the emergency department, and over half were able to name a primary care provider. Despite this, half of all participants had visited an emergency department in the prior 6 months. And we actually confirmed these as medical records and only counted those where we could find the record, so it's likely an underestimate. So while half of people had an ED visit, it was a small group of people who had most of the ED visits, with fewer than 7% accounting for over half of the visits. 24% of the visits were for a worsening of chronic illness, and 10% were hospitalized for a physical condition in the prior 6 months. When I created the slide about 2 months ago, we had 51 confirmed deaths out of our original 350 participants. I'm sad to say that we are now up to about 62 of our original 350 participants. Again, their median age is 57, who have died. We found 8 additional deaths amongst the 100 people we recruited in the past year. And those whose first episode of homelessness were after the age of 50 were twice as likely to have died as those with earlier onset homelessness. We have had more than 40 of our participants, more than 40 of our participants have had a nursing home stay. So what were the housing outcomes? I like to say that homelessness is a state and not a trait. By 18-month follow-up, the majority of our participants had regained housing, although we hit a plateau at that point. We got to about 40% of our original participants remained homeless after 18 months and have pretty much stayed there ever since. Where were people housed? This slide, I'm sorry, it doesn't look like it came out that well, but I think the main point here is that if you look on the left side of the graph, those are people who gained housing with any governmental support, either through permanent supportive housing for those with chronic homelessness, transitional housing through the homeless system, or subsidized housing such as housing choice vouchers. Half of the people who regained housing with no government support, either fixing it on their own and moving into a rental apartment or moving in with friends or family. I'd like to mention that as many people moved in with friends or family as those who moved into permanent supportive housing. And when we think about solutions to homelessness, we need to think about solutions that come from playing off of people's strengths, their connection to friends or family, and we need to figure out better ways to support friends or families to help their loved ones. So what are some interventions and solutions adapted for older adults? First of all, we need to do a better job with preventing homelessness. You can see that 44% of these elders first became homeless after the age of 50. Each and every one of those is a failure of our prevention system. For prevention efforts to work, they need to be both efficient and effective. They need to target those at highest risk of homelessness and then work to prevent it. We know from lots of studies that people who already don't have a lease are at the highest risk. Most people become homeless after being evicted. They then move in with family or friends and then lose that opportunity. And we know that targeting, that doing so and targeting to those at the highest risk is probably the best way to do it. We are working in California based on our research. California funded a large-scale program to target older adults involved in the adult prevention services system for homelessness prevention. We need tools to determine who's at the highest risk, and we need to make better use of our existing systems to identify these high-risk individuals, such as adult protective services, the healthcare system in general, and other social services who may be seeing these individuals. As I said here, to be efficient, you need to target those at highest risk. This is one of my favorite graphs adapted by Mary Beth Shin's work. If you see here on the bottom, you see the scale of risk broken up into deciles. So people on the right side with risk 7th, 8th, 9th, 10th are the people with the most risk factors for homelessness. If you look at them, and this compares people who got homeless prevention services and those who didn't. If you look at the left side of the chart where people had fewer risk factors, the good news is not that many people became homeless, but the bad news is that they didn't really become homeless whether they got the intervention or not. As you move up to higher risk individuals, more people became homeless, which may lead you to think that your homeless prevention services didn't work. but the blue arrow is where the impact of the program are. This shows those are the difference between people who got the intervention and people who didn't. You can see that if you focus on the highest risk individuals, you're going to need to tolerate more failures or turns into homelessness, but you are showing that your program actually was effective at preventing homelessness. We need to think about shelters and adapt them to the needs of older adults. And maybe in the question and answer, I can talk about some things that we've learned and some concerns about shelters in the COVID epidemic. Shelters have a role to play, but they are not housing. Shelters to work need to be low barrier. They need to allow people to bring in what we call the 4 Ps, their pets, their partners, their possessions, and to have privacy. They need to be housing focused. For shelters to work, they need to, from day one, have every effort focused on getting people out of the shelter. And as we see an aging population, we need to pay attention to older adults' specific needs, things like falls, confusion disorientation, victimization in group shelters. We need to look at things like bed height, having grab bars in the bathroom, lighting and noise reduction, and we need to think of ways to be able to get personal care assistance into the shelters. I want to highlight a really effective program run by Bax Bay Area Community Services in Oakland, California, where they did what we would call diversion or secondary prevention. They took older homeless adults and they tried to rehouse them, and they used a progressive engagement program. What that meant was they recognized that older adults' incomes can be fixed, but they worked with these 515 adults to maximize their benefits. They rapidly rehoused 515 people who were 50 and older using an array of services, including time-limited subsidies and services. What they did was they started with time-limited benefits and watched to see who it didn't work for. If people were not stabilized, they moved them into permanent supportive housing. They used a variety of models, including shared housing. They bought housing on the open market, and they put a lock on each bedroom door, and they put unrelated adults into each of the rooms and built a community. Bax holds the leases and is not going to evict people, but they're able to charge people very low rent to live there and provide support to them there. They gave subsidies for families if families were willing to take their loved ones in, and they helped people find apartments. They found that by doing this, about 15% of the people were not able to stabilize after a short-term subsidy, and they converted them to permanent supportive housing. So what is permanent supportive housing for older adults? Permanent supportive housing has shown to be effective housing for those with chronic homelessness and disabling conditions. It involves subsidized housing that's deeply subsidized, so people only pay 30% of their income, with linked supportive services that are voluntary. For permanent supportive housing to work, it has to be on a housing first model. You start with the housing, you make no demands of sobriety, no demands that people are engaged in mental health treatment or substance use treatment. You offer them the housing first, and then you offer the services, but you don't require them. It has shown to be extraordinarily effective at keeping very high-risk people housed. We have just done a study in Santa Clara County where we looked at the 400 most high-risk chronically homeless individuals. About half were offered permanent supportive housing. Amongst those who were offered it, 86% were able to be engaged into housing, and they spent 90% of their next few years housed, despite the fact that this was an incredibly high-risk population with many, many trips to the psychiatric emergency room, in and out of jail, many mental health and substance use problems. That said, we need to adapt this model for the specific needs of older adults. We need to think about how we do dementia care in this population. We need to think about how we allow older adults with complex needs to age in place, and we need to think about how we do end-of-life planning and care. To adapt this, we need to think about ways to provide personal care. Most of this could be paid for through the home and community-based services benefit by Medicaid, but there have been challenges in finding the workforce and in the fact that many of these individuals with complex needs are unable to manage their own care workers. And in many states, including my own, the home and community-based services are done in an independent model where the recipient of the services is supposed to manage, hire, fire, et cetera, their own care workers, as opposed to a contract model where these workers would work for a service and have a case manager, which will probably work better with this population. We've seen some PACE programs, or programs of all-inclusive care for the elderly, aligning themselves with permanent supportive housing to provide the care to permanent supportive housing residents. We face, particularly in high-cost regions, an enormous loss of residential care facilities, which is complicating solutions. And as I mentioned, we need to think about how to provide advanced care planning and dementia care in this population. So from some final thoughts. Homelessness is reaching crisis proportions. Older adults is one of the fastest growing groups. The aging of the population increases the urgency for a solution. The suffering of this community is immense. The use of the healthcare system can be chaotic with a lot of emergency department visits. And while mental health and substance use disorders are common, the underlying causes remain structural, the lack of ELI housing and structural racism. We must adjust systems to respond to the needs of an aging population. The solutions will not be easy, but they're doable, and we have to match the solution to the problem. With that, I will thank my team and leave you with my Twitter account where I post many things about homelessness and housing, particularly in aging populations, and my email address. Thank you so much for coming and participating. And I will turn it over to my colleague, Sherry Clark.
Thank you so much. Good afternoon, everyone. Thank you so much for having me. And Dr. Cuttrell, thank you so much for providing such an excellent overview of this such an important topic. It's a pleasure for me to be with you this afternoon. It's fitting that we're discussing this topic since May is Older Americans Month, and it's a time where our nation takes out to honor and celebrate our elders. We are all grappling with the COVID crisis, and vulnerable populations are certainly more at risk. This includes many of the programs I will describe today, which have had to adjust their service delivery to meet the new reality. At the Administration on Aging, we do not have funding streams that are specifically targeted to individuals at risk or are experiencing homelessness, but we do support and fund programs that can be used to provide support to older adults and persons with disabilities who may be at risk for homelessness. Today, what I'm going to do is provide you an overview of some of the Administration for Community Living programs with a particular focus on efforts funded under the Older Americans Act. And I will also talk about some other federal legislation and programs that I think you might find of interest. In addition, I will discuss a program that is funded by the Older Americans Act, but isn't housed at my agency, but it's with the Department of Labor. And then if I have time, I would like to basically go over a few project highlights so you can see how some of the programs I'll be discussing today are put into practice. First, I'd like to start with a little bit of history and a little background. In 1965, 3 landmark pieces of legislation were signed into law: Medicare, Medicaid, and the Older Americans Act. I'm sure most of you on this call, on this webinar today, are familiar with Medicare and Medicaid, but most folks have not heard about the Older Americans Act, even though it's a vital piece of legislation. The Older Americans Act created the foundation of a system of services and supports that enables over 11 million people each year to live independently as they age. The Act created an infrastructure that we now call the National Aging Service Network. And you can see from the slide that the Administration on Aging, which is within the Administration for Community Living, is considered to be the head of the Aging Services Network. And with that, we fund 56 state units on aging and over 280 tribal organizations representing over 400 tribes. And we also fund 618 area agencies on aging. The Older Americans Act requires that funding go to states and that states must divide their states into what are called planning and service areas in order to serve the populations within those planning and service areas. And then finally, we also fund aging and disability resource centers around the country, and that most of our programs would not operate if we didn't have local service providers and hundreds and thousands of volunteers to help our programs operate. These agencies are responsible for planning, development, and coordination of social, long-term care services and supports, and health support services within each state. Older Americans Act provides a framework for the delivery of a range of services for older adults. So these organizations at the state and local level may operate Older Americans Act programs, but they may also operate other programs similar to some area agencies may offer, states may provide long-term services and support through Medicaid, the State Health Insurance Counseling Program, the Public Health Services Act Alzheimer's Disease Supportive Services Program. So you can see that these agencies serve a vital role in the community. I want to talk briefly about some of the core services that we provide through the Older Americans Act. We fund a broad range of services that help older adults stay independent. These services can provide access support such as information and assistance, transportation being one of our vital services that helps older adults get to the doctor's offices, stores, or other events. We also support senior centers around the country that provide health and recreational activities. We also support case management, and we also support evidence-based disease prevention programs. In addition, we also have home and community-based programs, so we can support home health services, personal care services, and then our largest program through the Older Americans Act is our nutrition program, where we offer congregate meal programs at senior centers, at many of the senior housing developments, in churches, and in other places. And we also have home-delivered meals, as many people talk about. Meals on Wheels are provided through these programs. And in addition, we also support programs to assist caregivers. Many aging network agencies offer services to assist persons at risk or who are experiencing homelessness. A 2018 report conducted by the National Association of Area Agencies on Aging, funded by the Administration for Community Living, revealed that 43% of area agencies on aging reported working with homeless in emergency shelters, while another 21% of area agencies offer specific housing or homelessness programs, and an additional 14% reporting having a homeless intervention program, such as a targeted case management, day programs, or meal sites. Due to the COVID pandemic we're all experiencing, many of our programs have had to adjust. For example, I'm sure with many of you, most of our senior centers have had to close due to the crisis, so that many organizations at the local level have had to shift from their congregate meal programs to be able to provide meals for these older adults in their homes. And then many of the senior centers who may be providing education or health programs have actually tried to move to an online platform for those who are able to participate in those kind of programs. I want to talk briefly about our programs that are supportive of people, vulnerable populations. We have a legal assistance program that providers can help prevent homelessness among older adults by contesting unwarranted evictions and foreclosures in communities, and by representing long-term care residents and all in unlawful involuntary removal from long-term care facilities. Our pension and counseling program offers free legal assistance to individuals experiencing a problem with their pension, profit sharing, or retirement savings plans, or lost pensions and plans, and often helping individuals increase their income and be able to remain in their home. This program currently operates in 30 states, and the Pension Help America organization is available to assist individuals who are not in those 30 states currently covered. The Long-Term Care Ombudsman Program advocates for residents of nursing homes who wish to transition to homes or also defend residents against improper facility-initiated transfers and discharge that risk rendering older individuals homeless. We also support a variety of elder abuse prevention situations, and we also provide technical assistance to adult protective service programs around the country. Additional programs we support at the Administration for Community Living is the National Center for Benefits Outreach, Enrollment, and the Benefit Enrollment Centers. The National Center for Benefits Outreach and Enrollment and the Benefit Enrollment Center coordinates efforts to inform individuals about available federal and state programs. The center supports a nationwide network. There are currently 84 local benefit centers in 43 states, which is, that's a typo there, sorry, 43 states that provide benefit information and enrollment. Generally, the program helps people enroll in SNAP benefits, low-income home energy assistance programs, Medicaid, Medicaid savings programs. And it can also help individuals apply for programs such as SSI, transportation assistance, tax relief, and more. The State Health Insurance Counseling Program provides counseling to older adults and individuals with disabilities who are on Medicaid and Medicare, helping them to enroll, helping them during open enrollment and so forth. And the Medicare Improvement for Patients and Providers Act is a program that helps to do outreach to individuals who may be eligible for a Medicare savings plan or a low-income subsidy that would help pay for Part B premiums under Medicare. And then briefly, I just wanted to mention that we do have the Centers for Independent Living program at the Administration for Community Living. We fund 354 centers around the country. These organizations provide important services to persons with disabilities at any age. Key services include information referral to resources and benefits in the community, independent living skills to help older adults with disabilities navigate and thrive in the community, counseling from their peers, and services to facilitate transition from a variety of settings. And finally, I want to just briefly mention the Senior Community Service Employment Program, or CSEP. It's a program, it's the Old Americans Act program, but it is a program that is operated by the Department of Labor, and it was established to provide subsidized training and deployment for individuals 55 and older who are low income. And the program recruits and serves older individuals with multiple barriers to employment, with homelessness and at risk of homelessness. Risk of homelessness is a prominent focus of the program. And as you can see from the slide, in 2018, CSEP served over 55,000 people, and 61% of those individuals were homeless or at risk of being homeless. I just want to spend just a few minutes talking about several of the programs. You can see how these programs can be used at the local level. In Atlanta, the Atlanta Regional Commission, which is the area agency on aging in Atlanta, is working with 14 housing properties to help address behavioral health needs. So they have a behavioral health coach model where these individuals go into the housing and work one-on-one with these individuals to help they are usually referred by service coordinators to help individuals who are at risk of eviction or were disruptive in the apartment, and that many of these programs are really helping these individuals stay in their homes, get better connected to to behavioral health providers and so forth, and other supports within the community. And another project is in Phoenix, Arizona, and it's an area agency on aging in Phoenix, and they're working with the Justice Center Partnership. And this program is, the Justice Center is a resource day center for individuals 55 and older. And since 2006, the Phoenix, Arizona Area Agency on Aging has worked with this center, providing some of the Older Americans Act services that I talked about earlier, with meals, benefit enrollment, job training, and the employment programs and legal assistance. And finally, just looking at the Benefits Enrollment Center in Watts Labor Community Action Committee. This center is really trying to focus, it not only provides, benefit enrollment, but it's also looking at, it's a multi-purpose senior center that is providing case management, transportation, meals, and so forth. And then doing special outreach to homeless and older homeless individuals by providing outreach materials in the community, but also providing transportation to make sure and help individuals who are homeless or older adults get to appointments and other activities. For more information, feel free to visit our website at acl.gov, or for the employment program at Department of Labor, contact CSEP, or feel free to contact me directly if we don't answer your questions today. And with that, I'd like to turn it over to Brett.
Great, thank you, Sherry. And depending on where you're calling in from, good afternoon or good morning. Thanks for having me. Today, what I'm planning to do is provide a brief overview of the programs that are funded, through HUD's Homeless Assistance Grants and what types of housing and services they're able to fund. A lot of this is already described by Dr. Kuchel along with their benefits, so I'll go fairly quickly and hopefully leave a lot of time for questions. So HUD's Homeless Assistance Portfolio, this is the primary funding for dedicated housing to people experiencing homelessness in the country and in the federal government, is dedicated to assisting those experiencing homelessness and those at risk of homelessness. And we have two main programs: the ESG program, the Emergency Solutions Grants program, and the Continuum of Care program. The ESG program is the smaller of the two programs, and it's a formula program that is awarded to states, territories, metropolitan cities, and urban counties. The Continuum of Care program, which many of you may be familiar with, is our larger program, and we provide grants to state and local governments, PHAs, and nonprofit organizations. But the unique thing about this program is it requires continuums of care, which we define as a group of local stakeholders who have an interest in preventing and ending homelessness over a self-defined geographic area. They develop a plan to prevent and end homelessness, and then they send forward that plan to us along with their performance along certain metrics like reducing the length of time homeless, reducing returns to homelessness, preventing first-time homelessness. They send that to us as part of their application, and they select the projects locally that are going to fit into their plan to prevent and end homelessness, and then we score them and fund those projects as they rank. And now I'll walk through a little bit more of the types of projects that these programs fund. So as I mentioned, the Continuum of Care program is a competitive program. It funds two different types of housing: permanent housing and transitional housing. It also funds supportive services and data collection. For today, I'll focus on the permanent housing programs that it funds for time purposes. So we have two types of permanent housing that we fund under the COC program. the permanent supportive housing program, which Dr. Kushel already talked about, which is long-term housing assistance meant to serve individuals and families with disabilities. And it also provides funding for wraparound supportive services that are meant to be tailored to the individual or family and meant to help them obtain and maintain housing. So as you can see, this model can very easily be tailored to older adults with disabilities that were experiencing homelessness. But what we're hearing on the ground is that a lot of our housing providers are at a loss for how to best serve this population. And we'll talk about future coordination a little bit later. So they just need help with how to best meet the needs of their older clients. We also fund rapid rehousing through the Continuum of Care program. And this is a shorter term housing subsidy. It can be up to 2 years. And it also funds tailored supportive services to help people obtain and maintain housing. So when Dr. Kushel talked a little bit earlier about trying a progressive engagement approach, many of our communities will start with rapid rehousing, and they will start by trying to provide a shorter term subsidy, provide the wraparound services, and then if that doesn't work, they'll transfer them into permanent supportive housing and provide that longer term housing support. You can also use rapid rehousing, and we see communities use rapid rehousing in a situation where maybe you know that they need a permanent housing subsidy, maybe you aren't able to identify enough resources to help someone sustain housing on their own. But that permanent supportive housing subsidy, such as a mainstream voucher or such as a voucher from HUD's 202 program, isn't available right now. So you can use rapid rehousing as a bridge until that subsidy becomes available. For the ESG program, as I mentioned, this is a formula program. It funds street outreach, emergency shelter, rapid rehousing, and homelessness prevention. All of these can be vital steps in meeting the needs of older adults experiencing homelessness or at risk of homelessness. The street outreach services that we fund can help identify people who are living in unsheltered locations and places not meant for human habitation. They can engage them. They can have some of those problem-solving conversations to figure out what made somebody end up in the living situation that they're in now, and is there anything quickly that you can do to resolve that for them? Is there family or friends that you could connect them to? Is it as simple as paying a housing deposit to quickly connect them into housing? So you can use your street outreach dollars to do that. Emergency shelter can provide an indoor location for people to stay while suitable housing is located. You can also use it as a connection point for mainstream services and mainstream benefits. And then rapid rehousing is very similar to rapid rehousing under the COC program. You can pay for up to 24 months of housing support and tailored supportive services to help people obtain or maintain housing. And then homelessness prevention. This can keep people from losing their housing in the first place. Or if the existing housing that they are staying in isn't suitable, you can help move them into new housing without having to spend a night on the street or in an emergency shelter. And even though this webinar was scheduled long before coronavirus, and I can't even remember a time before coronavirus right now, thought it'd be helpful to put in a slide about the money that our office just received for responding to coronavirus. Our office received $4 billion under the ESG program for all of the services that I just talked about, all of the services and all of the housing, so long as it's related to preventing, preparing for, and responding to coronavirus. There is no cap on emergency shelter or street outreach services. That means that we can pay for these non-congregate shelters that communities are having to set up. Although we must acknowledge that we have to focus on rehousing, that permanent housing is really the solution to all of this. It also lets us target our homelessness prevention to those who are at 50% of AMI. Our traditional homelessness prevention is targeted to those who are 30% of area median income. And it's basically required to be housing first. None of the assistance that's provided under the CARES Act funding can require someone to receive treatment or perform any other activity as a condition for receiving shelter or housing assistance. And we have a lot of flexibility to waive statutory and regulatory requirements, so stay tuned. We're going to issue a notice to further define the program requirements. But again, this money is going to go through state and local governments, or states, territories, metro cities, and urban counties, and they will sub-grant it locally to other entities. I think to end, I would say we've come to a point where it's become more critical than ever for housing providers and our aging providers, our service providers, to coordinate. The proportion of the homeless population that is aging is increasing, and we're also seeing that older adults and those with pre-existing medical conditions, which many of the people that we serve in the homeless service system have a higher probability of contracting coronavirus. It's really crucial for the homeless service system to come up with models that will effectively meet the needs of these populations. So at the federal level, we've been doing having a lot of conversations about how to provide resources to you all to help you coordinate. But in the meantime, I'd really encourage COCs and homeless service providers to look at their own data, to reach out to those local area agencies on aging that Sherry just talked about, and start to come up with ways to effectively serve older adults experiencing homelessness and at risk of homelessness, combining the housing and the supportive services that will really help them be successful in housing. So now I will turn it back to Sherry. I promise to keep it quick so we can get into the question and answers. I apologize. I was struggling with my phone and could not get back to the unmute button, so I apologize for that. That was wonderful. All three of you gave us some really good information. We've got several questions, and I'm going to encourage all of you to jump in on these if you have something to add. So I'll start out with a question, and I'll start out with one of you, but then if everyone else would like to jump in and add, that would be terrific. So interesting stuff. I wrote down several things while all three of you were speaking. I thought that fact about half of the older people had not been homeless before 50, and that 56% of them were in fair or poor health was interesting. The 50 is the new 75 was an interesting point as well. So thank you. All right, I'm going to start with some of our questions. So Kathy Kirchner is asking, will you be able to offer suggestions today for resources for people who are not citizens who have dementia and no resources or support? Can any of you offer any suggestions for that really difficult population?
Yes, are these individuals homeless or just in general? Do we know in the question? I will
Kathy,
say that,
do you want to add anything?
I'm sorry.
Oh, please go ahead, Sherry. I apologize.
Oh, no, that's what I was going to say, that the programs I discussed, the Older Americans Act programs, those programs, there is no citizenship or requirement for those programs. So, you know, certainly those programs could potentially be used for the individual. We do have programs that can support individuals with dementia. So, I mean, like I said, we don't necessarily have homeless programs necessarily, but, you know, the programs that I did talk about, they might want to reach with their local area agency on aging to find out about programs in their area.
Yeah, and for HUD's homeless programs, and I can only speak about HUD's homelessness assistance portfolio, so the COC and ESG programs, we've published a fact sheet that we can put in the public chat that talks about how our resources, thanks Kate, can be used to serve people where you don't know their documentation status. And it essentially says that street outreach, emergency shelter, and rapid rehousing assistance under both those programs can be used to support people regardless of their immigration status. There's also a difference in our programs between whether you're a nonprofit provider or a state or local government. Nonprofit providers are not required to ask about immigration status. If they do, they have to just ask everybody. But I guess there was a decision that it can be a burdensome process, and that was not something that they were going to ask nonprofit providers to do. But all of that is laid out in that fact sheet that we put in the chat. Perfect, thank you. Margot, do you have anything to add?
No, I think that covers it. It certainly is. It in some places can be more challenging than others, and this is a place where I would disagree with what was said, and also say that like faith-based communities have played a big role in this population as well.
Thank you. Right. So Damian Gibbs is asking about, do you all, about demographics of military service homelessness, presumably with the older population. Do you have anything to add there? I know here at least, many of the older folks who have been homeless, who have been chronically homeless, are coming out of even Vietnam still. So what are you seeing with regard to military service in your research, Margot? And then we'll move on to Sherry and Brett.
Yeah, they're definitely overrepresentation. We're still seeing some Vietnam era as well as some later conflicts. That population is overrepresented in the homeless population, and we saw quite a few of them in our study. I will say that because of the work that the VA has done and the HUD-VASH program has done, that folks with a military background in our study were some of the folks more likely to get into housing programs with those supportive services. So definitely disproportionately impacted by homelessness, but also because the VA has done such a tremendous job with rehousing programs, that they have had a little more access to successful supported exits from homelessness than others. But definitely seeing both still Vietnam era as well as later conflicts are now aging into that 50 and older group.
Absolutely. Thank you for that. Sherry, do you have anything to add?
No, thank you.
Brett? No, I don't. Okie dokie, we're moving on. So Jorge Gomez is asking, and I think this is probably for you, Dr. Cashel, are nursing homes entered in the studies?
So if you were living in a nursing home, you would not be counted as homeless, if you were permanently in a nursing home. What we have seen is a tremendous number of people with short-term nursing home stays. So we definitely have seen very large numbers of our study participants enter into acute rehab programs, sort of acute nursing home programs after hospitalizations, where they have stayed for less than 90 days and then were discharged back into homelessness, unfortunately. We've had fewer than I expected actually exits into permanent nursing homes, although we certainly have had some. And if individuals are in nursing homes and they are still able to give consent, we have been able to follow them through their course there. I would say that I predicted that there would be more nursing home stays, and in fact what we saw was a lot of short-term nursing home stays where at this point people were probably sort of ending their Medicare beneficiary period. People were discharged and often discharged, unfortunately, back into homelessness.
Thank you. Anyone have anything else to add there? I don't, I think it was pretty specific to the research. So I'm going to move on to the next. This is a comment from Erica, but I think it would be a good thing to discuss a little bit, maybe the three of us. So what Erica says is many of our most vulnerable who were moved into permanent supportive housing with substance use issues ended up being kicked out of the units due to damage, inability to get along with roommates, not being able to follow the rules, excessive hoarding, etc. because the assistance was voluntary, most of the residents chose not to use them and instead to continue with substance abuse. So I would just say permanent supportive housing, housing first, are not housing only, and oftentimes connecting people to the services means using your motivational interviewing skills when they start to spin out of the housing to get them back on track. So I'm going to just start with that, but who would like to tackle this beginning of this?
Yeah, this is Margot. I would say, we've learned a lot about permanent supportive housing and sort of what the secret sauce is. I think one thing we all need to perhaps do a better job on is getting the right level of services to the right people. I agree completely that housing first is not housing only. And I know that what is called permanent supportive housing, varies in the resources available, right, all the way up to assertive community treatment with sort of a physician-led, 1-to-15 ratio team, through intensive case management, which may not have that medical component, but still has very low client-to-staff ratios, down to folks where the resources for services are just not there, and so there might be a project-based building with one case manager for, 80 people. And so what we certainly found is that the higher the need of individuals, people with these really complex behavioral needs, probably at least in the beginning need more intensive services. And so, for instance, the Santa Clara study that I talked about had an intensive case management program led by licensed clinical social workers. They aimed for a 1-to-12 to 1-to-15 ratio. They didn't always get there with their team, which included a peer case manager and a licensed clinical social worker. It was, it hovered between 1-to-15 and 1-to-20. One of the most interesting findings from that study, which I hear time and time again, is that a huge proportion of the individuals needed to move. They did get evicted once, but they built into that program, they sort of anticipated it. And people do their lives stabilize over time. And so they had the capacity to move people. If the first eviction would have meant that they lost their housing, I think we would have seen really different results. We saw, and I'm trying to remember it offhand, but it was, I think, at least half of people had at least one move, and often more than one move, where people sort of burnt out of one place and moved to another, but they stuck with them. They actually built into this program some sort of flex units where they could sort of move people temporarily while, after they'd been evicted. And that was really what their success is. I realized that program was geared towards very, very, very high-risk individuals. But I think the secret sauce to their success was both having this intensive staffing model. They had close connections to mental health care in the community to augment their care, as well as physical health care, as well as substance use treatment. They were doing lots of motivational interviewing, and when they, had that moment of opportunity, they were able to jump on it. But I also think having this ability to anticipate that people might not succeed in the first place that they are placed, and that, in fact, is really common with this population. And so anticipating that in advance, obviously this all takes resources, but that was really their secret sauce, is that they had a landing pad for people so that they could sort of temporarily house them between units, and they had the ability to move people into another unit, and that was really what was a success. I think that high staffing ratio and coupled with the ability to move people more than one. Now, there are some supportive housing populations that aren't as impaired, but I do agree with the questioner that in these very high-need populations it can be very challenging, but definitely housing first is not housing only. Don't underestimate the amount of staffing you'll need, and have the ability to be able to rehouse people, because what they found is, most people stabilize after a period of time, but it did take a while.
Excellent. Thank you for that. Sherry or
Brett?
Go ahead.
Yeah, I would add on to that I agree with everything that was just said. And also, when you're shifting, if you aren't already at a housing first model, just acknowledge that it can be harder. And your staff need training, and you need to support your staff in the skills like motivational interviewing. And as Dr. Kushel said, eviction doesn't have to mean termination in our program. So certainly in the COC program, you can help somebody move. You can transfer them to another PSH program. Think about roommates. It works for some people. It doesn't work for other people. And kind of be able to move and be flexible. And I would also say find a way to not burn your landlords. And that takes funding too, but we've seen some communities set up mitigation funds. They're able to provide extra security deposits. So they're able to, even though one person maybe doesn't work in a unit, they're able to then move that person to another unit, and they haven't lost that landlord in that unit for somebody else where it might be effective.
Absolutely. Great. Thank you, Brett. Sherry, anything you'd like to add about this?
No, I thought that was excellent.
Thank you. I agree. I think understanding the permanent supportive housing model, I will just take a moment here to plug the SAMHSA's Permanent Supportive Housing Toolkit. It's excellent. You can go to the SAMHSA website and download it, and it's sort of soup to nuts how to put together a PSH program. But I agree that one of the most important things you could do is get somebody into the right unit to begin with. Certainly, you know, I've seen people put in congregate settings that really didn't do well in congregate settings. But once they were moved into a small individual unit, they did great for years on end. So, you know, it can really just be knowing your client as well. All right, so I am going to move to another question. We've got quite a few, so I doubt if we'll have time to get through all of them. All right, so we've got a question here from, I think it's ISPA, and I apologize if I said that wrong. So how does someone who's homeless get started seeking help? Do they need a referral from a case manager or from a local community agency? Brett, would you like to start this? I think your Continuum of Care does a spectacular job with connecting people.
Yeah, so if you haven't been located yet by an outreach worker, all of our continuums of care are required to set up something called coordinated entry. And this is a process that they use to sort of, unfortunately, there just isn't enough money to serve all of the people who are currently experiencing homelessness. And so coordinated entry is a way that communities do an intake, they prioritize, they assess. They're going to have that problem-solving conversation with somebody, hopefully. In some communities, it's a 211. In other cases, it's a intake spot. So I'm guessing in light of COVID, a lot of those intake spots have moved to virtual. In some cases, wherever you are in the continuum, if you're on the street or if you're in an emergency shelter, your caseworker is going to be able to connect you into coordinated entry. But that's really the hub of a lot of the resources, both dedicated to people experiencing homelessness and mainstream. And a single intake can connect you to a variety of different resources that you might be eligible for.
Thank you. And I will just take a moment to say path workers are another avenue to get connected into the system. So if someone is experiencing homelessness, PATH, Projects for Alternatives and Transition from Homelessness, is a SAMHSA program that practices outreach and engagement with people who are literally homeless or at high risk of homelessness. So you can go on the SAMHSA website, samhsa.gov, and type in PATH, and you'll get to a place where we can put the link in as well. But you can
and on the HUD website, we also have, you can link in, find your continuum of care and enter your geography, and the coordinated entry contact is on our website as well.
Thank you. Absolutely. So PATH and continuum of care are both easy to find and figure out who is working in your community. With PATH, you may want to start with the state PATH contact, who can tell you who can tell the person who to call. So Sherry, did you have anything to add from your perspective on this piece?
No,
How
except
to
for
get
like in the
connected?
aging space, if individuals were to contact a local aging information referral specialist, that individual could certainly help get that individual connected as well, if they've already in that aging space.
Absolutely. And I think a lot of our community action agencies or human resource development councils around the country have a lot of those programs under their umbrellas, so they're wonderful to work with. All right. Margot, did you have anything to add to this question?
No, I think
Okay.
agree with everything said. Yeah.
Perfect. Okay. Well, let's see. I'm looking for another question. So Tony Schaefer said, do you have any tips on working with older adults who are homeless and need nursing facility care but are not believing that they need it? That's a tough question.
Oh, I'm sorry.
Thank
Yeah,
you.
it is a tough question. I think as far as I'm concerned, in that kind of situation, connecting that individual with the local area agency on aging would be a good thing, because we have individuals there, information referral case managers, who are trained to be in those kind of situations, help those individuals, to talk to them, do effective interviewing, have those connections in the community. So I think in my mind, that would be one of the first places I would try to connect with those local aging agencies in order to make those kind of initial connections.
Sure. And this is a question, I would take out of this conversation. I mean, at what point do you call adult protective services? I mean, that would be a question that I would have. And I don't know if that falls under your umbrella,
Yeah,
Sherry,
adult
or
protective
not.
services, sure, we could certainly connect people to adult protective services as well. But I understand what you're
really
saying,
hard.
where would be the entry? Yeah, as to determining where it would be. That's what I was just suggesting, that is connecting with the local aging, area agency on aging initially to do some initial assessment and then moving forward from there.
Perfect. Thank you. Anybody have anything else they'd like to throw in on that one? We've got about 49 seconds left, so I'm going to go to one more question. Okay, so Pat Turner is asking, do you have any suggestions about how to manage people who are considered in need of long-term supports for housing, especially those with aging issues who, due to COVID, are in hotels or homeless and really need higher levels of care? They're connected with some services, but decline additional supports for housing. They believe they can live independently, but others have assessed them as not. So this is really similar to the prior question. Does anybody have anything to add here? I think this is a hard, this is hard. It's complicated even more deeply by COVID.
Yeah, and and it really gets into sort of ethical issues. I always wonder if some of what we see as sort of absentee or whatever is in some ways a sign of dementia, and particularly that executive function, issues. And then it really gets into the deep ethical issues of when do we declare that people are not able to make their own decisions, or how do we support them to make safer decisions? So I guess I would just acknowledge what an incredibly tough situation it is. And then to just think about how much can we support people, and at what point does it edge into a question of capacity? How can we provide the appropriate support for people?
Thank you. Anybody have anything they'd like to add? We are 6 minutes from the end of this webinar. This has been a really exceptional webinar. I would just invite each of you to say, if you could say one thing that you've learned through your career doing this work, what would you say to the folks who are listening today, just sort of as what do you want them to take away with them?
I guess maybe I'll I'll start and say two main points. One is how many of our friends, neighbors, and fellow Americans are really living on the edge, and how much, elderhood is such a risky period for this. And so I think we all need to redouble our efforts to make sure that we have the ELI housing necessary for people, to make sure that we have those safety nets there, and to make sure that we're actually asking people about their risk of homelessness every place we see them, and intervening quickly. And then the second thing I would say is that I'm always humbled and amazed by the work of our colleagues who work in homelessness services, and the hard work of really of believing in housing first, and providing those services, because you see people at one point in time, and their lives seem so chaotic, and what we've seen are these incredible outcomes, and it's not always pretty, and it's not always linear, and it can take a long time, but really the belief in sort of second and third and fourth chances, and sticking with people, and just realizing that people have had traumatic lives, and sometimes we need to just follow them where they go, but stick with them, and that there can be success.
Wonderful. Thank you. Sherry, what would you like people to take away?
First, I would just like to thank everybody who's joined us on the webinar, because it shows there, to me, a desire to learn and be connected more, to be supportive of older adults. What I have learned is the importance of advocacy, and the importance of being there and supporting older adults at all levels, and that I've been amazed by the work that's done at the local level with homeless providers, but also with our housing providers and our aging network providers who are out there doing yeoman's work, and many with limited resources, and really doing what they can to be supportive of older adults at all levels, whether an individual is at risk of homelessness or not. It's just being there and being supportive, and really making lemonade out of lemons sometimes, because the money is just not stretching where it used to be. Especially, I can say in our Older Americans Act programs, money has not kept pace with the need, and but these people are continuing out there to do what they can to be supportive, and I just admire what they're doing at the local level.
Thank you so much. That was lovely. Brett, you get the last word.
Oh, great. I just have really come to appreciate how hard this work is, and how much the people on the ground who do this work, how much it is just your life and your passion, and you give so much to your clients. And so thank you for that. And I do think that I have learned that the onus is really on us to make our programs easier to use, easier to coordinate together, easier for people experiencing homelessness and older adults to access, because, as Sherry said, the resources aren't growing, so it's up to us to help you all use them more effectively. And I think we all need to come together and just find the right supports and the right housing interventions for people as they age, so that the only options are not nursing home or something else, that we have a need to help them stay in their communities.
Thank you. Wonderful. We are totally out of time. Zach,